afternoon, so we wanted to go ahead and get started with the meeting. Might have a couple folks wander in. I think we don't have anybody new at the table, so no need for introductions. In terms of the content of the meeting today, and I don't know if there's anybody online, but in terms of content of the meeting today, we are going to go back over the scaling, the MHAC scaling with Shuli presenting to talk about the demographic adjustment, and then to focus a major part of discussion on the draft report that we want to move forward to the commission meeting on the balanced update and short-term adjustments. So that's a busy agenda for the day, and with that, we'll turn it over to Shuli.
Good afternoon, everyone. So what you have in your packet is the final version of the scaling for MHAC. And I appreciate all the time that the subgroup put into it to help me to think through things and the discussion that we had. So in the first table 1, scaling parameters, what we have is 2 scenarios. If you remember, we had 3 scenarios that I presented to you in the last meeting, and based on the feedback we got in terms of making sure the levels work fine and make it more simple, we reduced that into 2 scenario case, and the threshold for minimum improvement is 8%. So if statewide, the PPCs they don't go down by 8%, then the maximum penalty applied would be 4%. If we exceed that threshold, the maximum penalty is going to be 1%. Then not all the hospitals will receive penalty, even in the scenario 1, in our worst case scenario, and the threshold is there at 0.5%, but there will be no rewards. And then we have a limit for the total revenue, which I'm going to get to in the next slide, is 0.5. In our best case scenario, we have some rewards for the higher performing hospitals up to 1%. With the condition that we have the available funds from the penalties assessed. And again, the state total penalty applies here too, but given the scaling results, we think that that's probably not going to be applied. Then if you turn to the next page, the way we were proposing the scaling to make it more predictable was to use a fixed point scale for scaling. So this is based on final calculations. So basically, I would disregard the hospital name for a minute. If any hospital in the performance year scores 0.14, they are going to be penalized, and if the state is at 8 or below, they're going to be penalized 4%. So that's going to be known for the hospitals ahead of time. And if we are exceeding the 8%, the corresponding penalty for a 0.14 score is 1%. And then if you go down to the bottom, you see that the cut points for no penalty zones and then the reward zones. So it's based on the score of each hospital rather than the ranking of each hospital. Then I'm going to skip to the results section, which all these things get together. We modeled, the 2 scenarios. One is the 8% improvement and one at 12%. So blue shade is the 8% improvement, our worst case scenario. And the green shade is our, I would say, expected. So that's the average of the last 3 years. The way the scaling works is, so we, as you see, the lowest score in the model in the blue shade is 0.22. The corresponding penalty is 3.14%. So that's the penalty applied to this hospital, and then we do this on a continuous basis up to 0.5. Any hospital between 0.5 and highest score gets no penalty in the worst case scenario. If you look at the total penalty, then it's $98 million overall. And then here is where our statewide penalty limit applies. We set it to 0.5 of the base revenue, which is equal to 36 million. So we reduce all the penalties in proportion to the difference between those to reach our maximum penalty. In the green scenario, the differences, as I explained, one is we are starting with 1% penalty, and second, we have hospitals that will be receiving rewards up to 1%.
Sure.
I hope I didn't go through too fast. If you have any questions, I'll be happy to answer. David.
Shuli, can you hear us on the phone?
You need to get closer to you, David.
I think either of the hospitals not lined up or a keying error, because look at GBMC. It doesn't affect the concept here, but just to get it cleaned up, you got GBMC at $807 million in CPE revenue.
Yeah.
But I don't know if it's the wrong hospital or the number's just keyed in wrong.
Right, it could be some sorting errors there.
And I don't know how that affects the rest of the.
It will affect. That's a good point, actually. The maximum collected will depend on where the hospitals are. So, even if you ignore the names, if you just look at the revenues, that's how it's calculated. Yep.
It doesn't affect
I'll
the
clean it up.
concept,
Yeah.
just the numbers.
Thanks.
Hey, Shuli, can you explain really quickly how you go from the 4% to the 3.14?
So that is the second page on yours. So let's see, the highest score is 0.22. So in the second page, you find 0.22 score, and then corresponding penalty is 3.14%. And we are under 8 in this scenario. If we are above, then it's 0.75.
Surely, but these are just hypothetical scenarios, right? So in theory, every hospital could end up being penalized if everybody does badly, or every hospital could end up getting out of the penalty zone if everybody does well enough, right?
That's correct. Right. Our modeling is very unrealistic. We are assuming linear 12% improvement in all PPCs in all hospitals, which is not going to happen for sure. That I'm sure of.
I just wanted to thank you for all the work you and the staff have done on this. I know we've gone through a number of iterations on this, including with the subgroup meeting a little over a week ago. I think this is reflective of a lot of the conversation that's gone back and forth with our membership over the last several months, so I do want to express that appreciation on behalf of the hospital field. And again, I think being sensitive to the need for making sure that even in the scenario where hospitals might, on a statewide basis, might not achieve the 8% targeted reduction, sensitive to the need to having sufficient resources still left within the system to allow them to make further progress, further investment in improving on those results, I think is reflective of the cap that you've put in here. So I do want to express my appreciation for that consideration.
Thanks. The other thing I'm sure we're going to get into in the report is what do we do with this money? Because if we take too much off, since these are one-time adjustments, we inherently destabilize our trends because of these adjustments. So that's the other concern, and I'm sure we're going to get to it in the discussion part. And the readmission, there is no change on the readmission scaling for the moment. All right. Should I move on to the demographic adjustment? Yep. Okay. Can I have the button thingy? So before we went into more detailed discussion, we thought it would be good to give you some general explanations on how we calculated the demographic adjustment. And this is another subgroup that we are planning to meet in April, and we'll get back to you at the end of April with some modifications and final methodology. So the idea in the population growth is, as you know, our target is on a per capita basis, so we have an allowance of 0.7% population growth in the revenue. Although in this statewide calculation, we don't have any age adjustment, when you think about the global budgets and where each hospitals are serving, it's imperative that you do some adjustments to this population because there is a variation in hospital use, and I just put age and sex, but there might be other factors. So when we looked at the global budgets and how much expected volume could be because of these changes in population growth and demographics, we considered several factors to calculate that allowed volume increase or expected volume increase. The first one is defining hospital population growth. If you think about a hospital, if they all serve the county, let's say, and they are the only hospital, then their population growth is the growth in that geography, basically. But since we don't have that well-defined geographies for especially the GBR hospitals, we looked at the proportion of hospitals' volume in a set geography, which we use as zip code. So based on that proportions, the market share, if you will, we calculate the population for these hospitals, and then we looked at the aging of that population and weight these population growth based on the average charges by age groups. In theory, basically, we're looking at a population growth for a defined area, which we call virtual patient service areas. And then we're looking at if in that area, if there is a higher aging, if the elderly is growing much higher, then and the volume growth, expected volume growth is going to be higher in that region. And once we did that, obviously, if you're looking at the trend in terms of hospital use by age, there are some expected efficiencies that you may observe under the global budget. You probably don't want to build everything from the historical trend because our whole idea is to break that cost curve. We employed the efficiency adjustment, which is the avoidable utilization percentages for each group. So the youngest population usually doesn't have that much avoidable utilization, whereas the elderly has a lot of readmissions and a lot of preventable admissions. So we reduced their utilization based on those percentages and calculated an adjusted rate. And finally, aligning with our variable cost factor, we used 50-50% for that expected volume growth. I realize it's very complicated and probably it will take us at least 2 hours to get through the detail, and I'm hoping I will have some interesting discussion in the subgroup, but I just wanted to give you kind of the concepts and main variables that we start using it. The work group, the sub-work group is going to be looking at whether we need to have more detailed age groups in the adjustments, and also whether we should add not only age but maybe sex or gender to the calculation adjustment, and how we should do the efficiency adjustment in the volume calculation. And also, I think there might be some little changes to be done to how we calculate the volume and how we calculate these percentages for the virtual patient service areas. How is that? Did I just mumble everything in your head?
I may have missed something. Have we set up this subgroup yet or gotten volunteers for that subgroup yet?
We do have volunteers in terms of scheduling. I think they are on our calendars. I'm looking at Denise. The first is April 11 to the 4. April 21st to the 4. And then if you haven't received and if you're interested, we can always add you to the list.
I think I have a couple of questions. Are you defining individual hospital service areas? And do we have a sense in Maryland how competitive service areas is? How do people go to multiple hospitals, or they tend to go to only one hospital? And are you looking at just the population that a hospital is serving, or are you looking at meaning the patients, or are you looking at the community that the hospital is located in?
So this is really not an attribution model where we're looking at where the patients are going. What we are looking at is, if you think about a zip code, and we do it by age, within a zip code, what proportion of volume is going to hospital A versus hospital B? And according to that, we just assign a population. So we are not assigning that zip code to a particular hospital where a traditional primary service area, you have a list of zip codes.
But you are assigning essentially a population to a hospital.
I'm assigning a number.
The end result is, that you get a population assigned.
Right, but I'm assigning.
And it's based on the people living in a portion of this zip code and a proportion of that.
Right. So it is a number at the end. It is not an individual person, right?
And then.
Right.
But you're extrapolating that to the residents.
So then the population count I total based on the residents, right? So if you think about, if I just use inpatient visits, right? So proportion of, if the 50% of inpatient visits were hospital A, then 50% of that population are assigned to the hospital A.
And it's really the population change from that area.
That's right.
So if 50% of them are coming from Anne Arundel County went up 10%, they would get a factor.
Right.
So if you'll have this right, then the only error would be, just to exaggerate and make a little example here, if the population growth, if all the young folks went to the hospital that's outside the primary service area, but all the old people went to the one inside, that's where there would be a misallocation of this adjustment. But that's never going to happen.
No,
It's
not. We are not assigning anything.
By age group. The market share was calculated at each age group.
Right.
So if you have two hospitals, and let's say young, and you have one zip code,
Right.
young is going to hospital A, and elderly is going hospital B. All the young population then is assigned to hospital A, and we look at their population growth there.
Okay, I didn't understand it before.
Right.
Got it. Thank you. That makes it a little bit better.
Are there two different calculations for TPR and GBR?
Yes.
Do you think that GBR is better? Do you think you should consider it for both? You don't have to answer me. Okay, but I just wanted to lodge the concept that if you believe you have refined, we spent a lot of time, right, looking at market share, demographics, primary, secondary service areas for the TPR hospitals, and looking at lots of demographic calculations. If you've refined that, then perhaps we should consider that.
It's possible. The TPR hospital contracts have demographic factors assigned in them for 3 years. But that doesn't mean that if the TPR hospitals wanted to change their demographic factors that we wouldn't accommodate that. But I do have the microphone. Maybe my voice was just a little raspy there. So to repeat again for folks on the line, the TPR contracts have 3-year adjustments built into the contracts. So we didn't necessarily indicate that we wanted to open up the contracts and change all of the factors, but we didn't say that we haven't said that we wouldn't do that either if it were requested. So we just haven't really formally considered it.
But if the TPR hospitals want to address this issue in this subgroup, can we add that to the list? Is that what you're asking?
I think what Don is saying, they have the right to come in if they want to change the calculation on an individual basis, or they can stay with the 3-year contract that they have today. I mean, the contract is what it is. We spent a lot of time negotiating it, but I hear an opportunity to revisit it if you want. Did I hear that right?
Yes.
Thank you.
And this again may be a question more for the subgroup. Can you define, and particularly for some of the folks new around the table to this issue, what you're including in potentially the PAU, potentially avoidable utilization for that adjustment?
Yes, that's a good question, and it's still in refinement. But it includes all 30-day, all hospital readmission revenue, potentially avoidable admission revenue, which is the ARC measure, Agency for Healthcare Research. It's sometimes called ambulatory sensitive care condition admissions, PPC cost. So that's the inpatient side. And the ambulatory one is the weakest one. We have only 30-day ED visits and observation stays within 30 days of an inpatient stay.
Returns to observation
Right.
or within 30 days.
Right.
There you go. Thanks. Technical difficulties. A question, and maybe you pick it up on your third bullet on that page. I like the idea of breaking up by age cohorts, but the question really is it going to be allocated in the same way? Because the cost associated, obviously, with a 0 to 14-year-old is a lot different than the cost of an 85 plus. So is that going to be picked up in your equivalent case mix adjustment?
Right. It does.
Just one quick question, and I don't mean to make a big deal about this, but just to make sure that others around the table who may not be listening to a word, when you adjust this for, the policy not to continue with more PAUs, the word potential is in that, and I hate to have everybody assume automatically that because we have a defined population that we have to remember the word potentially avoidable. Some of these, as we well know, are not avoidable. And I don't want to make a big deal about it because I'm not, but I want to make sure that we don't use it as a way of saying, in fact, all of that's avoidable, when I think evidence would suggest otherwise. But we also know that there are other PAUs that have not been identified for this purpose yet.
Right.
So anyway, the word potential means something.
Yeah, right. And also, the way we are doing right now is just for the growth rate, if you think about it, right? It's
I know, that's why,
right.
That's why it's not working.
It's a limited, yeah. All right. Well, I see a lot of discussion, so I'm looking forward to continue this in the subgroup.
So now moving on to the next agenda item, which is really getting into the draft report and the plan of attack here is to walk through the draft report section by section to see what we are focusing on in each section and to get comments. And I realize that it's a thick document and that you didn't have so much time with it, but that's the schedule that we're working on. Our focus is on getting your comments and then developing a document that we send out to the commissioners tomorrow, and then having an opportunity to present to the commissioners next Wednesday the draft document. It's not going to be our final recommendations, but really an opportunity to review where we're headed in terms of policy recommendations or the recommendations that we want to get in front of begin to get in front of the commission, which will be taken up in the in the May meeting. So that's what we're trying to accomplish today. And if we get started on a section and we aren't and we're getting hung up on a particular section, we'll take a time out and come back to it just because we have a lot of ground to cover here. And so we won't fail to come back to it, but we'll move on and then come back a little bit later in the conversation. So I think the what we've done with the document is to set up that that there are 3 categories of hospitals or revenues that we need to adjust moving forward. Note there are hospitals that are under global budgets, hospitals that are not under global budget, but they're regulated by the HSCRC on an all-payer basis, and they're in the all-payer model. And then the third category are hospitals where the HSCRC sets rates. They're not part of the all-payer model, and CMS, Medicare does not pay the rates that are set by the commission. So that we have those 3 distinct categories of hospital revenues that we have to develop an update factor for in July. Does anybody have questions about that or comments before we dive into the details?
I just have one brief question. Do you have a sense of the ratios of these 3 categories?
Yes. So category number 3 is a relatively small proportion of the total revenue. I don't know off the top of my head. I think it's about 3 to 5%, somewhere in the 3 to 5% of statewide revenue at the maximum. Yeah, it's fairly small, very small. Right now, we're still in negotiation on global budgets. Right now, we have 50% of the remainder of the revenue on global budgets, and we're hopeful to bring that north of 80%. So that's our plan of attack. But right now it's 55 actually. So so the next section of the document lays out the goals and desirable features, and we started we went into started discussing these before. We had a subgroup rework these. We've gotten comments in from several parties, and we've tried to reflect those comments in here. There may be some additional questions or discussion about this area of the document, so I wanted to open it up to allow discussion on the goals and desirable features.
Well, I'll start to kick off based on the feedback that we had already shared with staff. On your second bullet point, I think while I understand it's a very general and obviously important goal, it can be misread or misinterpreted. Specifically, you could meet the all-payer model requirements, particularly on the cost side, simply by lowering hospital prices. And so when we had looked at this, the hospital field had suggested that this bullet, in fact, be revised to read that the goal should be to support hospitals' ability to meet the waiver requirements. So that it's a question of providing sufficient rates that'll give us the resources we need to meet these waiver requirements. So again, one might say it's a semantics issue, but I just want you to understand how the hospital field is reading that particular bullet based on our past experience over the last couple of years, where because of the declining waiver cushion, we lowered all payer rates. So again, that was the edit we had suggested, and again, I just want to make put that out on the table for others.
Are there other comments on that? I'll make a comment on it. So there are two bullets right below that that I think address what you just brought out. So it says, provides hospital with overall fair and reasonable compensation, provides rates and revenues that are sufficient for efficient and effectively operated hospitals and equity among payers. So I was thinking that that was already being picked up right in close proximity, and so that it was redundant. So that was the thought process of the of editing the of it being focused solely on hospitals, because it's not, you know, it's also about patients and payers, and so, you know, just wanted to keep that context there, that the all-payer model requirements with the limit are based on providing, you know, better care, better health, and lower costs for the benefit of patients. So,
Donna, I think I certainly would agree with what you're saying, and you know, it'd be hard to go into this with a position of not stating what, you know, these are very general comments,
right,
and their goals. And I would agree that our goal is to meet the requirements of the demonstration. So I think it'd be hard not to have a bold statement like you have here. And I agree that you kind of hit the other, and I certainly understand what. Well, I would argue then, Donna, you've got the all-payer requirements in bullet number 1. Promotes the 3-part aim of the all-payer model. So I see that's why we interpreted that second bullet to be referencing more the financial requirements of the waiver, and in fact our concerns regarding the fact that based on recent history we were lowering all-payer rates to meet the requirements of the old waiver. So that's, you know, again, what I would argue, if anything, if we think there's some duplication, we just eliminate the second bullet altogether. Well, the second bullet I see as, yeah, okay. But the second bullet I see as, you know, we have 2 quality measures or targets, and we have 2 financial targets, and I see that as saying that we're going to be able to reduce PPCs by 30% over 5 years. We're going to reduce readmissions to the point of hitting the national average, and then we're also going to be able to hit the 3.58 and the $330 million savings for CMS. So I think you need that in there. I mean, they're the requirements from our perspective.
Would it help if there was language added to the preceding paragraph, to the lead in here, that kind of made what you just said clear, say, you know, in the context of, you know, we have to meet this test. In the context of that, we want to make sure that we, at the same time, achieve the triple aim and are fair to all parties involved. And this is the set of goals that we lay out to try to do that. And that way, it might make you know, it might make the hospitals more comfortable without, you know, dropping the need for the test, and it makes it more explicit up front, and then you have the 4 bullets. And it will only take a sentence or so to do that. Would that work?
Again, as I don't want to argue over semantics, I really just wanted to make sure folks understood the comments that we had raised. Rather than sitting back and forth and trying to convince you to change the language on this, you know, I think there's some duplication in points 1, 2, and 3, as I've pointed out, and I think that could be resolved by just eliminating the second bullet point, but I don't want to belabor this anymore. We've got a lot more we have to get through this afternoon.
This is Jim McGee, and I'd just like to say that if you make that change, then you have 3 of the 4 bullets referencing hospital concerns. I don't see anything here about patient or community concerns. So I agree with John. I think leave it the way it is. Hence do.
Okay. Well, we can leave it the way it is, and we could also go back and pull some language. Actually, there was some language that might work in the preamble that came from the advisory council report that actually would provide that preamble language. So we can take a look at it and see if there's something that does that. And I think we have a fairly long list of desirable features here. Did anyone have a comment on the list of desirable features?
Just a quick question. In the original version of this that we had for our last work group meeting, under the desirable features, you had a bullet that talked about other requirements such as capital are considered inadequately addressed. And we've dropped that in this version, and I'm just wondering what the thinking was on that.
Most of these others weren't so specific as to an item, but I don't think that we would object to adding it back if folks want to see it added back.
I didn't have any problem with it being in there the first time.
So are we going to spend any more time on the
Well, I wasn't going to read through them. I was just wondering, I wanted to ask if folks had had a chance to look at them and if there were other comments or questions. So this is kind of a, I'll call this an executive summary of what the advisory council wrote about it. So the issue is that the hospitals are taking, taking really the risk, if you will, of the new all-payer model, and because there's one pot of money, there could be a tendency to not cooperate and not collaborate, and it's really important. It's really important for hospitals to work together to do care management and to make this model work. And if one hospital doesn't work with other hospitals, it can really foul the waters, so to speak. And so, the thought process is that if hospitals have a strong consensus about how something should be done, and that consensus isn't about exactly how much is going to be paid out the door, so something that the payers have also an equal concern in. But if they have a consensus that a significant consideration should be given to that, because it is consensus and it is the field working together. So that was actually something that was addressed, and that's why it's showing up here again. It was contributed in the comments. So what is your thought on that? Do you think it belongs here? Or do you
well, I absolutely do think the point about collaboration among the hospitals belongs. I absolutely agree with that. I'm just wondering if we should add to that, and I don't know how we would affect this, but I'm just wondering to what extent should we talk about the importance of collaboration with other healthcare providers? So I understand the point about collaboration among the hospitals. I think we all know for this to work, hospitals have to collaborate with physicians, pharmacists in the communities, nurse practitioners in the community. I mean, I'm just wondering, do we reflect that need for collaboration outside the hospitals with other healthcare providers?
We have a point kind of in the middle, and maybe that needs to be strengthened. So it says physician and other provider alignment.
That was one of our guiding principles. I think Ray has added to that by also suggesting that if the state finds a way to reduce those assessments, that shouldn't open up the avenue for them to use that reduction to increase assessments somewhere else to fund other governmental needs, that we should be able to keep those savings within this regulated system and help to achieve the goals of the waiver.
I think this falls under a slightly different category than the rest of the recommendations, because most of these really apply to what the Commission should do or what the system that the Commission is promoting should look like. You know, this is sort of like telling the state or the governor or others, because all these assessments were applied, obviously, as budget reductions for the governor. However, there are some assessments too, keep in mind, that are used to help reduce cost. You know, their assessments for Maryland Patient Safety Center and CRISP and other things like that. So just keep that in mind as well.
Steve, is there a place you would suggest that principle be implemented? And I understand exactly what you're saying. I mean,
then that should be taking into account if we were you know, focused on increasing assessments, and that has a negative contribution toward meeting the all-payer requirements, then I think it is picked up there in that policy issue. I'll think about another way of writing it, about being cautious about adding to, or about the adding to cost to the system that would detract from the ability to meet the requirements. So that could maybe fit into your thought process, because I don't think there's a strong disagreement with the thought process. Now, when you say no assessment increases, that's a very personal issue, because our commission funding comes out of the assessments, and we do have an increase in for this session,
which we supported wholeheartedly in the General Assembly.
Perhaps, yes, you could look at different wording around reductions in assessments, legislated. But then you're getting into telling the legislators what to do. I hear what you're saying. But it is a burden for all of us, payers, Medicaid, Medicare, when we put these assessments in place. And I think we all recognize part of the failure of the waiver test could be as a result of not addressing those particular assessments. So if you could give that due consideration, I would appreciate it. Thank you.
I just had one last item in these desirable features I'd like to explore, and it comes out of some of the discussion at the Advisory Council, where you've got a number of bullet points that talk about fostering collaboration. There's clearly, and particularly within the bullet on value being rewarded, situations where hospitals should be allowed to compete on that value equation. So I'd like to somehow see somewhere in here a recognition that regional, statewide collaboration is not always the best way in which to encourage and promote value, that sometimes competing on that value equation between and among hospitals is an important feature as well. I don't recall the exact wording that the Advisory Council used, but I know that was an issue they raised in their final report as well. So I'm wondering if we can find maybe a sentence or two from that report to either add or expand on the value is rewarded bullet point to reference that issue.
Yes, and someone else had raised that outside of the meeting, and I do think that that we can bring that bullet point in. So basically, just for folks who aren't seeing that bullet point, it's to set up the notion that when patient, it's about market share. And it's when patients move from one hospital to another hospital that we should allow the money to follow the patient, but with with a few caveats. And so the caveats are that it shouldn't undermine the model, and it shouldn't punish hospitals who eliminate avoidable volumes, and it should not punish hospitals who eliminate excess capacity. So that's kind of the gist of what the Advisory Council report said, and it was a carefully crafted statement that was a balanced view of that point of competition. So I think that we could incorporate that, because it was very, it was discussed at great length and carefully worded. So we'll incorporate either exactly that or an executive summary of that, if that meets people's need.
So I have a question regarding the bullet number 4 about policies being communicated effectively to the general public, which I do think is an important thing to have here. I wonder if we should add policies and performance can be communicated effectively to the general public. Because I wonder to what extent is a goal, a desirable goal, to be able to disseminate information to the public on how the hospitals perform on these quality metrics in the aggregate, and perhaps also individually. Because I think going back to what Mike was saying about competition, if all this great stuff is going on in the hospital community, but yet the general public and the payors, the plan sponsors, the employers, the multi-employer funds don't actually ever see this data in terms of how they compare, are we missing an opportunity to get good information out to the public?
Sounds reasonable. Any other comments about that?
And there's certainly the argument that this is way too complicated for people to understand, but I would like to push us on, to the extent we can, make this meaningful to the general public and to the people who are footing the bill, the employers and the multi-employer funds. I think that would be a desirable goal for what we're doing. I don't know if Jim has.
I agree.
Okay.
So, Don, I have one other point, and maybe it's here and I'm not seeing it, but I've been around a long time, and I remember days where I felt that all parties in the process were more collaborative than I think that, honestly, we have been in the last many years. And I'm wondering, and in particular, I'm thinking about payers and plan sponsors, that we need to go back and promote some of the innovation and some of the payment ideas that maybe we can create as to how other providers are paid to help this overall expectation for the cost of health care to go down, so that the hospitals aren't in isolation trying to manage. In reality, we may be 40% of the cost, but we're going to have to spend a lot of time with the other 60%. And to the extent that we can have payers, plan sponsors get on that playing field and be collaborative in that regard, so we're not fighting some payment issues that may exist, and do it together, I think would be a very desirable outcome.
I want to second that point. That's a great point.
We'll add a bullet point on that. I think that is a very good point. So it's about collaboration, innovation, and really getting that community, the payer community, involved in helping to get alignment in place.
I think it's the source of a big win. So Hank, maybe an example would be you can keep a lot of patients out of the ED if their primary care networks are in place to offer alternatives so that they don't end up in an ED. But that's a collaborative process between the payers and their networks and the availability of care versus our struggle, obviously, to keep those individuals out. And that's a common occurrence where the patient comes in and does not have an alternative, even though they have a plan. And what we would like to, do you have extended hours in the primary care offices, urgent care centers, and some of us now are actually making those investments just to keep those folks out of that ED. And so there's certain type of cases that actually produce real problems for us as the hospital, and it's way too expensive to treat those individuals in ED. So I think there are examples of collaboration that we should put in place that could really make an economic, and truthfully, it's a much better patient satisfaction experience than hanging out in some of our EDs.
I'd just kind of like to weigh in on this topic a little bit. It's a little too near and dear to my heart. As a plan sponsor, purchaser, one of the challenges that we face is exactly what you're talking about, engaging the patient population. And, we hire vendors to do that. We hire CareFirst or Kaiser or a disease management firm or a pharmacy benefit manager, whatever. But the pushback we always get is, why are these people calling me? I get all the information I need from my doctor. And so I really think that this whole process of care management, this is, from my perspective, has to be moved upstream to the source, the people who deliver the care, and get them engaged in a more meaningful way. And I think that's happening in a lot of ways, a lot of innovative ways, and I think that's what attracts me to this whole initiative, because I see that as a major stimulus to that. But I balk at asking us to do more than we're already trying to do.
And then more of a monitoring question than necessarily anything to do with the points, but what type of external resources are we looking at to judge whether the financial health of the hospitals is sufficient? I know we have financial condition studies, but you know, we come off, and I think, Mike, you drove some of the comments from the industry. You know, we come off a couple hard years of a lot of hospitals losing money from operations, some being downgraded, obviously, by the rating agencies. And clearly there are opportunities for all of our entities to be more efficient and address some of these issues. But if we were in one of those situations, I hope never to return to it, where we indeed were seeing hospitals losing money from operations despite all their efforts, seeing more and more downgrade. These are community assets. Would that be triggering something in the minds of HSCRC that, guys, even though we think we're following the language, we have a situation here that needs to be dealt with? I assume the answer to that is yes, but I want to make sure that those third-party assessments of our industry are being looked at as it relates to fair and reasonable.
It's a theoretical question right now, so Jerry can weigh in with or Steve can weigh in with a theoretical answer.
That's fine.
And I would say that when we look at financial targets, so now I'm not talking about rapidly deteriorating financial conditions, so I'll separate that from financial targets. That we would be wanting to look at them at the same time as we were looking at efficiency. So if we were engaging in a study on financial targets, we'd also want to engage in a study on financial efficiency at the same time.
I agree
so
with that.
I don't know if Jerry had any other additions to that.
Mike, I think, you know, I read into the fourth bullet under the goals, that discussion, and I believe that discussion is first starting in the performance measurement work group, and then perhaps we'll move to this work group as well, is the discussion of defining what that efficient and effective, those series of measure or metrics would be, around which we could then do that evaluation. I think we first need to have the common definition that we seem to have lacked over the last couple of years.
The only point I raise is there are other people outside the state that look at our organizations and make some value judgment. We've always gotten the plus associated with that we're in this HSCRC system. They have always historically seen that as a good thing. I just want to make sure we maintain that and that we're all able to keep reasonable ratings on our facilities so that we have access to the debt market. Again, we're not-for-profit organizations. Without access to the debt market, you know, the reinvestments in our facilities just can't happen. So it's just one of those external factors that, as long as it's on a plate somewhere, and I'm not saying it's the only thing on the plate. You have plenty of things to evaluate, but the external view of our industry is actually very important to us.
This is affirmation under the goals that we recognize what the requirement is and our responsibility is as a HSCRC. And in terms of the timeline to discuss it, we wanted you to get an update this year. So we wanted to discuss it after the update was done, because it's one of those topics where there's it can take some lengthy period of time to come to an agreement. So we didn't want that to get in the way of the update process. Are there other comments, or do we move on?
Racing through. It just off of Jim's comments, I'm assuming you all agree with some language in here about payer collaboration, innovation. Okay, I just want to make sure that that's where you were going. Okay.
So we have a background section from page 3 to 7 that really is just going through how we have done things.
And I'm sorry.
That's okay.
Arrived late, but since you're still just, it seems like finishing up the third page. Oh, thank you.
Thank you. All right, pushing the button. So I arrived just in time to ask one question. Under the desirable features, before you move on, and maybe folks will tell me this is not the time to do that, but the next to the last bullet, which someone just mentioned about the fostering collaboration and consensus, there is, at the end of that bullet, among hospitals, and maybe at this first stage it is limited to among hospitals, but I wondered if it makes sense to leave among hospitals out or just bracket that out, because it seems to me like the underlying goal of what's being done in Maryland is to, in the universal sense, foster
Barbara,
that
you hit
environment.
deja vu right on the head. So we actually
Did I hit the discussion? Okay.
So we'll tell you what the resolution was. So
Okay.
we're talking about physicians and others up in the middle, and so we're going to add more explicit language about also collaborating with physicians and other providers. And we also added a point about collaboration with payers. And so we've covered the waterfront, and everybody else had the same reaction you did.
Thank you. Thank you.
So we have a multi-page background section where we've described how we've done things in the past, and describing the models that are in place, and the general concepts that we're going to be teeing up. So I guess on pages 3, 4, 5, and 6, does anyone have questions or comments about the background section?
Just a quick question on page 5, and it's, I guess you'd say, the second full paragraph on that page, where you talk about the bridge or transition policy that the Commission put in place for January 1 through June 30th of this year, that if Maryland is found to have exceeded the 3.58% growth rate, that the Commission will recover those costs by proportionally adjusting either the July 1st update factor or the approved hospital revenues. And maybe this is the point, the question here I have is, that I've raised about the difference between how we monitor things or measure things on a calendar year basis for the waiver versus setting rates on a fiscal year basis. Because what I would argue here is that we only allow in this description for adjusting if there's an overage in that first 6-month period of time, but we say nothing if there's an underage. And we don't have a policy yet that we've discussed or agreed on, but I would argue that if in the first 6 months we were found to have been below the 3.58% ceiling, I think there needs to be some consideration or discussion done as to what we do when we set rates for the first time under the new waiver for July 1st. So I think it needs to be both ways here, both overages and underages. So I'll just open that one up.
I personally would think that it would be too early to make an adjustment for an underage. It may well be too early to make an adjustment for an overage as well. So I think actually a lot of the hospitals have made mention that if we think things are going over, that we should make interim adjustments in conversation. So I think really maybe we should change the word from will to may, and really leave that and ask the Commission to leave it more at the Commission's discretion. If we have a plan, we're in a transitional stage, and so it may be that hospitals are getting their charge compliance in place, and by the end of the year we have a very specific plan of how we'll be right, smack on target.
I'd be fine with that if we say may instead of will.
I think that would be a reasonable. At the point that we wrote it, we didn't really know what people were going to do contracting-wise, et cetera, and so forth. So I think it would be reasonable to change that to May. Other comments?
I do have a question on page 5. And I think this is really just a very basic question about GBR. So maybe now's not the forum to cover it. But to what extent could hospitals limit volume to benefit under GBR simply by not having the capacity ready to take care of patients who've traditionally gone to that particular facility? I'm just trying to understand, how do we mitigate the risk of, that the surgeries that used to happen on a 3-week time frame now get pushed out to a 7-week time frame because there's no incentive, right, to see the patient as there was under the old model. I don't think the old model was the way to go. I'm just trying to understand, under the new model, how do we make sure that the patients are still getting in and getting the care that they need, even though the hospital is getting a set amount of money? And I think that's the kind of question employers will want to ask. How do we make sure people are still getting the care that they need under the Global Budget Revenue Program?
So I think that's a good discussion to have, and we do have a contract subgroup to review the contracts, and there are a number of provisions in the contracts. If you all have suggestions for changes to the contracts, we are going to go through them and would certainly invite participation in the subgroup. And also, in terms of design issues, of continuing to take comments on design issues. But I mean, there's ultimately a number of things, but at this point, we weren't planning to get into those in this particular report. That's really more of when we start talking about market share and shift and the contract and taking responsibility. So I think we're picking back up on that conversation immediately after we finish this one, if that's okay to leave that. But we're not going to leave it for very long, just for another month.
Yes, and I didn't realize that would be under the jurisdiction of the Global Budget Revenue Subgroup, but that makes perfect sense that we cover it there.
Well, it's not under the jurisdiction, but I mean it's coming back. They're going to review the contract, and then others may want to contribute to that discussion as well. But yes, that's very much part. That it has a number of patient protections in mind in the contract. So if there need to be a few more, we're here to listen.
So Donna, can I make one point? I know you want to end this. If I can make one point, I think this is why the principle of promoting competition is a good thing, and we don't want to discount it because I think it would really limit what you're talking about.
And that's one of our primary interests in promoting the money follows the person is if Hospital A is going to put a lag in their schedule, guess what? Hospital B isn't, and Hospital B is a high-value, high-quality place. So let's take the money and put it where they're going to serve. So that is part of that. Part of why we're putting that statement back in, because we really do believe that is patient protection language. Are there other questions about the background section?
One last comment on that subject. There are provisions built into the contracts that restrict hospitals from eliminating services or modifying them significantly. So if one does that and closes a service, then one has to give back the revenue. The commission staff has already done that, and they've done it in various situations. They always debate the amounts, but they have done so. I'm not sure competition is always the best thing, Hank, because sometimes that could drive hospitals to get into more capital expenditures and drive cost higher. But I understand what you're saying, and I understand the language that you wish to put in there.
So now are we out of the background section? Okay. So now we're moving into the section that's going into a description of the balanced updates for the all-payer model. And the construct of that section is that, first of all, it goes through in a general way and talks about the considerations in developing an update factor that will result in a balanced budget. And then on page 8 of the document, it goes through a very detailed example. So we didn't necessarily, because we didn't have to account for all increases in revenue in our old method, we didn't necessarily have these long models to consider, but with having to account for all sources of revenue increases in developing and considering what an update could be, we've outlined all of the items that came to mind that might be looked at in determining what an update factor could be. So I might just quickly walk through that page to tell you what's there, and then you can ask questions about the details of the descriptions or make comments about the details of the descriptions, etc. So we're calculating the maximum allowed revenue growth, and I should probably mark this again as an example. We might want to mark this as an example and not as a recommendation, because this isn't a recommendation but an example. So we go through the calculation of maximum allowed revenue growth, and so we calculate that with our per capita amount plus our population growth to come up with an allowed revenue growth of 4.3% in the example. And then we start filling in the blanks, and so if we determine by looking at global insights that the inflation allowance is 2.3% in this model, we've filled in a 2.3% adjustment for global budget hospitals, and we filled in a different allowance for non-global revenues, and that's a policy issue that we'll get into, but we're just working our way down through the calculation. So we have a certain amount of money taken for inflation. Then we have adjustments for volume, and we have global budget revenues adjustment using the population method that Shule discussed. This theoretical example here is higher than you would expect on average to come out of that model. If you looked at that model, it would be a lower amount. But we do have a couple of considerations, and we just used a slightly higher example. It could be that, in theory, if all hospitals that had low population updates chose to stay on the CPC, then you could have a higher population allowance on one, and you could have those lower population adjustments coming in under the volume governor. So the non-global revenue number here is representing what might come through on the CPC hospitals. And the policy that we currently have in place has a volume governor limit of approximately 2%, 2 to 2 plus, and so I've represented that here as, because it's 50% variable cost, and I know this is all complicated, as a 1.2% limit, so that translates itself into the table as a calculation. And so I think you asked earlier, well, maybe that could be 50% of the hospitals if not everybody goes onto a global budget. So ultimately, how the number of hospitals that go onto a global budget will affect how this table would come out. Then I think we talked earlier about the global budgets generally providing an infrastructure into this current fiscal year of 0.325% on average. And the next item, which is discussed later in the document, is an allowance for the opening of the Holy Cross Germantown Hospital, that opens in the fall of this fiscal year, and we'll go through the details of how that might be calculated. And there are other increases. So we have an increase in uncompensated care that would be funded under our policies. I've put an allowance here for unknown adjustments, and we used to call that slippage. So I'm trying to come up with a different title than slippage. But pardon me? No, I mean there are different things, and Jerry can give you some examples of what those might be. Then in this model, we're looking at reversing the prior year shared savings reduction, but don't worry, we're putting it back in at the bottom, and we might add to it. Any positive incentives that we might have, and I don't believe we have outside positive incentive programs this year. Then on the flip side, we have uncompensated care reduction. I think we're actually looking, potentially closer to 1%, but just for the example purpose, I put 0.8% because people start attaching things to numbers. Then and I don't know where it is in the legislative process, but we have the MHIP assessment reduction that would start sometime in the fall, assuming it makes its way all the way through, and then we have the shared savings coming back out at the bottom at the level that it was put back in, and it could be actually more coming out, so it's not necessarily limited to a -2. It might be -4. So anyway, that's just really the example of how we get from the top part of what's allowable to where we might end up with the various components that would be put into place.
Point of clarification: it's the bottom number that you have there is a total revenue growth number, not a per capita number. Is that correct?
That's correct.
Okay, thank you.
So I should
Again, only because it might get confused with our statewide ceiling of 3.58% per capita.
How about if we just convert it back to per capita so people would actually know what it would be on
per
capita?
Or just by adding a line, I think. So you'd say total revenue growth of the 3.59 and then convert that to per capita would be helpful.
Okay. So now there was a detailed description following, I think, following that of what these components are. Does anybody have questions about the what's in the table or how it's presented or the description. Does this do a good job of presenting what we need people to understand, the field, the commissioners?
Yeah, I actually have a little a first question of clarification here, and that has to do with the non-global revenues, because as I see it, there are two types. There's the hospital revenues that are outside of global budgets for the CPC hospitals, for charge per episode hospitals. And I know that comes in, as you're describing this, under that category of non-global revenues. But there's also revenues associated with non-Maryland residents using Maryland hospitals that are not subject to that 4.31% total revenue limit. Now, while many of the hospitals who have completed global budgets at this point have put those non-Maryland resident revenues under their global budgets, not all of them will. And I'm wondering whether, for presentation purposes, we need to differentiate the CPC hospitals from the non-Maryland resident revenues in this model.
Well, if in the detail, we've actually included them in the same category of adjustment. So they are under the waiver. So Medicare has set a waiver for rate setting for those individuals, and so we're still setting the rates and still putting policies in place that Medicare has delegated to us the authority to put effectively to put policies in place over the revenue for those individuals. And there are a considerable number of Medicare patients in that out-of-state area. And so we are including them in exactly the same category as the hospitals under the CPC.
Right. And what I guess I'm arguing is that in describing or starting this off with a discussion of what's under the all-payer target, we're now also including something that's not part of that target. Even if the commission may want to use, the staff may decide to recommend the same policies or constraints on that non-Maryland resident revenue, I think that's a policy discussion we need to identify, and we can only do that if we separate that out here in the chart.
So basically, then, as far as this chart goes, it really is just Maryland residents. So that's the point that you're raising, yes, that I'm being dense on.
Yes.
Sorry. Yes. Okay, so I got it. I've got it.
Okay.
So
thank you.
For non-global revenues for Maryland residents. Yes.
Don, I know we'll be talking about this later, but more broadly, the CON adjustments obviously relating to the new hospital in Germantown. I'll hold my comments specifically to that till a little bit later, but having a capital policy is obviously very critical, but I am a little worried about how big that list could become overall in other years. And by the way, we have one in the mix, so I have a vested interest in some policy. But at the same time, I do worry a little bit. I'll hold my questions, but I want to raise it now because you asked for comments. The CON adjustments, depending on the year, could be significant for the industry, and I don't know if it's something that's actually totally affordable if it's not well managed and thought through. Again, specific to this one, I'll hold till later.
Well, we do need to actually have a capital policy, and unlike your CON, which is after the new model, if approved, is after the new model was approved. This one happened beforehand. So the commission made a specific policy exemption for this hospital. It's fairly unique in that it's a new hospital. There's really not too many new hospitals being built in the state. So it's a very unique adjustment, and I think the whole capital policy issue is one that we have on the agenda right after the balanced update is done, for the same reason as the other conversation was right after the balanced update was being done.
So that helps me because now I know I can really say my comments later in the conversation. It won't impact me later, so that's all good.
So it needs a lot of work. It needs some help from Mr. Parker, and so I think that's another meeting.
I'm good.
If I can, just moving down to the set aside for the unknown adjustments, and I did note that we used to call that slippage. It's interesting. First of all, this Germantown Hospital in the past, if I understood that calculation, would have been included in that unknown adjustment. It would have been something that we would have included in that calculation. So it would be helpful, maybe not for today, but I think if the members of the work group could get a sense of the kinds of things, and in past years what that adjustment has averaged. In some years it's a very small number, in some years a large number. And the only reason I raise that is that this is just perception versus reality. I mean, the fact that you put a number down here, even if at the top you put in not a recommendation, that's a very sizable number to set aside against the total revenue target. And I'd like to, at least if there's some historical basis that says it's roughly average 0.5, then I think we all need to know that. I do know since I've been here, it's been a much smaller number than this, and there are other things than just these certificates of need that have gone into that calculation. So if we can just have a list of the kinds of things, and maybe for the last 3 or 4 years what that number has averaged under the old model, that would be helpful. Because then maybe we might decide that for reading purposes, for optics, we might want to select a different number or a lower number than this 0.5.
This is Jim McGee. Would it be more accurate to say set aside for unanticipated adjustments rather than unknown adjustments? Oh, that's a question.
Sometimes we actually know it's coming. We just don't know what the dollar amount associated with. So.
I don't know.
Now you know why they chose slippage.
We're going to use slippage, I can tell. So Don, if I could just make sure I understand the total slippage, I'm going to use that word that may be here. That one's identified specifically, but if we have in this example a 4.31 total maximum allowable revenue growth, and at the bottom of this we've allocated out net number of 3.59. The difference between those is roughly 0.7. So we had that on top of the 0.5 slippage before we feel like we've bumped up against this cap. Is that accurate? Am I interpreting this page correctly?
Yes, I mean, it might not be before we bumped up against some other policy considerations, but definitely before you would bump up against this cap.
Right, right. There's some belts and a little bit of suspenders here. That's good. I mean, it is. I'll just make sure that we all saw this.
We're hopeful. You know, we're hopeful that the uncompensated care adjustment and the MHIP adjustment would give us a little breathing room on this and the Medicare test.
And I guess that for me also another way that I'm looking at that adjustment, with everything that we've listed out there, there can certainly be some clearly unanticipated situation where an individual hospital has to approach the commission for some unusual, a disaster, something highly unusual that was not reflected in their global budgets that they need to reflect. And that is clearly one of the kinds of things that we'd be talking about here. We'd hope that those would be very, very limited circumstances, but I view that, if you will, as a commission flexibility line item as well. I think you need to have that in this world of global budgets where we can't be so prescriptive on every single line item that we don't have that kind of flexibility to provide for those unusual exceptions.
Donna, where are the demographic adjustments included in here? Maybe I'm confused. Maybe I wasn't listening. I apologize.
Under bachelor number B.
Bachelor number B?
Adjustment for volume.
Okay.
So that's where we have, for the global budget revenue, so that is population adjustment. And that number is on the high side. It's intentionally just a little on the high side in the example. Other questions?
I just wanted to commend the comment that I see here about, here, thank you. This is Stan Doran impersonating Vinnie DeMarco, standing in for Vinnie. I just wanted to commend the comment on page 9 about how the HSCR staff is proposing that volume changes be recognized in annual rebasing of global budgets, which I think reflects the point you made earlier, Donna, about money following the patients. I agree with you. That is a consumer protection because it does limit the kind of incentives that David was talking about that are potentially risky for consumers. And I guess I was wondering how the staff was envisioning that kind of a rebasing would work.
I'm not sure where we're looking at rebasing. So I think we're looking at updating the annual budgets for population adjustments.
Right.
And we're looking at the potential of making market share adjustments, which is a follow-on conversation to make market share adjustments. So that market share adjustment is the if you will, the part of the exercise to address some of the consumer issues. So that is something that we do that ad hoc, and we've done it in the middle of the year. We've done it, but we could do something that is more formal annually, but we actually do it whenever we need to address it. So if it comes to our attention that we need to adjust something in the middle of the year, a program's discontinued, it's switched, it's something major happened, we've addressed it any time. And the contracts allow for it to be addressed when it needs to be addressed.
So the business about annual rebasing of global budgets, I was curious to know what thinking was underneath that comment.
I think that's referring to the population and demographic adjustments. You know, that number is going to be recalculated every year to predict what that volume growth is going to be.
Got it. So that wasn't so much referring to changes in the case mix. Okay. So that conversation will have to await. We're all sort of getting, jumping at the bit here for the
contract group, which should be starting very well, and that'll actually start sooner. I don't know if we have dates set yet, but we have one date set, and I know you're going to be part of that group. So we're anxious to get your input on how to make sure we get some more details into the contract where needed.
Yeah, and it also fits into the market shift.
Yes, and there are some other things in that contract too that are really consumer protection that I know that you may not have seen yet that we'll bring to your attention as well.
Thank you.
Thank you. Are there other questions on the table? Any other comments about making it more understandable or useful? Then in the several pages behind that, there are descriptions of that table. Are there questions or comments on the descriptions that go with the table?
On page 10, under the positive incentives, you talk about that staff is proposing a positive incentive program. Is that the readmission policy that you're referencing there? And that's where you say for fiscal 16. Thank you.
The answer was yes.
Thank you.
That doesn't affect this year's balance update, but it's a placeholder, and it does actually have to be put into long-term modeling when we start looking at the impact of multiple things over time.
Further down under the shared savings reduction, I think I'd suggest a wording change where you're talking about adding back in the at least the 0.2 for shared savings. In the last sentence, you say if the commission added to this adjustment, the reduction would increase to 0.4. You probably need to say if the commission doubled this adjustment. That's the only way you get to the 0.4. If they simply added to the adjustment, you don't automatically come to 0.4. It depends whatever they add. So I'm just suggesting we either change the added to read doubled as an example. Yeah, if, for example, the commission doubled this adjustment, the reduction would increase to 0.4.
Okay. And I think that's good to say, for example. Yes. Thank you. The very end of that page, you talk about the other items that we make in the model, and you talk about price leveling, and this may be more for folks who are new to this process sitting around the table. Could you or Jerry explain what you mean by price leveling of revenue adjustments? So, and I don't know where you're reading from, but I know
bottom of page 10, the very last sentence.
So something could have happened before the beginning of the period that we're looking at. So something could have happened in May. We're looking at an update on July 1, and if something happened in May that caused the revenue stream to increase for the following year, then we would be needing to take that into account.
Okay.
So,
thank you.
So that's what that's all about, and
okay.
it gets then when we switch between fiscal year and calendar year, that adds another layer of complexity. So we need to be able to bring projections into place in looking at the impact on multi-year model. So even though this kind of does it on a theoretical basis, then the HSCRC staff needs to be able to tell the commissioners, well, look, we ran all of these models, and even though we have this theoretical model of an update, we have all of these other revenue streams moving forward, and so how does this what's the actual increase when we apply it to the revenue stream?
Thank you.
So all of the quality initiatives are meant to be revenue neutral for rate setting purposes, correct? So that on an individual hospital basis, a hospital could be penalized for their relative performance, but in the aggregate for the industry, it's meant to be revenue neutral?
For fiscal year 15, that's correct. For 16, the new policy removed that requirement that we may have reductions more than the rewards. So they are no longer revenue neutral.
So okay, maybe I did not read that in here.
I actually noticed that on the page on the on page 8 on 3, we need to add D as the net impact of one-time adjustments.
Okay.
To account for that.
Good.
For 60.
So we can add a category for negative incentives or something.
Well, I should add this year, in the old impact methodology, some of you already know, none of our hospitals are penalized. Everybody performed better than the benchmark, and I'm hoping we're going to keep continuing that way.
Are we leaving that section yet, or we have more?
The only response I'd say is there was a time when under QBR there were incentives that were provided, and it wasn't completely revenue neutral. So maybe. Huh?
Each of those folks
were always revenue. Were they? Okay, I'm assuming.
So QBR currently is still revenue neutral. MHAC is not. MHAC is negative. There is a possibility of getting more, and the readmission is a positive incentive.
So the next section is about the materials that Dr. Cook so eloquently presented at the last meeting, and I've tried to boil them down to a fairly short section here, summarizing the results of the model that was presented to us, which basically says that if we take the actuaries' projections, the CMS actuary projections, and we apply a savings factor to that, Medicare could go up by 1.25%, and we could still achieve the savings that we need to achieve under the model. And then going through the adjustment factors that tell us how to think of that in the context of an all-payer rate setting limit. So I've used a table from his model to go through that description, and then I've written the steps that describe that table, step 1, 2, 3, 4, and 5, and now I want to see if there are any comments, if that gets the job done, et cetera, and so forth. That work for you?
Yeah, I think it was summarized well.
Okay. Others have comments or questions? So then I have a little section here on the calendar year impact, just explaining that we have to model it both ways for commission consideration at the end of the day. Now, okay.
I think in that section, that distinction we just made about non-global revenues for Maryland residents versus non-global revenues for non-Maryland residents needs to be in here as well. They seem to get, again, lumped together here.
Thank you for unlumping them. So now we're going to move on to the next section, which lays out the considerations for the balanced updates for each type of hospital. We're reminded again, or revenue stream. So with number 1 being revenues under global models, number 2 being revenues under the Medicare waiver that are not paid under a global model, and they're under the all-payer model and under the Medicare waiver, but not under a global model. And then number 3 are revenues that are where HSCRC sets the rates, but they're not under the Medicare waiver. So that's kind of the 3 distinct revenue streams that we're talking about here. And I guess, and Mike, I think actually when I go back and adjust that other section, I need to say, never mind, I'll just leave it there. I was going to say I actually need to think about just I need to pull out the global, even if it's under a global budget and it's out of state, it still doesn't belong in the accounting where we're trying to account for the cap. So this really needs to, adjustment for inflation policy adjustments. It's really for Maryland residents at the end of the day. So sorry for going backwards there, but so those are the categories that we're teeing up here. And then we start through a chart that lays out some possible considerations that we've discussed, but we haven't really discussed in specific detail some of the things that are in the chart, where we start with looking at where do we get the inflation factor, then what are we going to do to the inflation factor when we get it? And in the on one side we're looking at revenue under global models, and the other side we're looking at non-global models. So in the non-global side, we're really walking down pretty much the same process, a very similar process, the same process that we've used pretty much in the past to arrive at an inflation factor to be applied. So we're reducing the global insights inflation for policy adjustments, for productivity adjustments, and part of that reduction is because there are different volume growth available to those hospitals, and other reasons for that differentiation are for policy reasons, meaning that the global model is has a potential to secure the revenue more accurately for the state, and it also favors, it also has the potential to drive more population health initiatives and efforts to reduce avoidable volume. So in this write-up, we're saying that factor should be at least 0.7 of a point lower than the factor that's applied to the global model. That's how we have laid out and contrasted to what might be done with the global model.
Donna, I'm sorry, just a basic question. The column, I'm trying to understand how the columns map to the numbers that are on the previous page, at the bottom of 13.
Why don't we actually put the numbering on there? That's a good point. So number 1 would be going on the right-hand side, and so maybe we should actually switch them so that they would follow the sequence. So number 1 is the right-hand side, and number 2 is the left-hand side.
And what threw me on number 2 was when I see that it says it's Medicare waiver exempt global models. That to me sounds like it's a global model. I think you mean non-global.
I think we missed a word there.
Yeah. I kept trying to rationalize maybe I'm just not understanding something, and I never could figure it out. So, okay, we just missed a word.
I think we have a typo there.
Okay.
Yeah, and this is, boy,
sorry
I really hate.
Sorry for this.
I really hate to make this even more complicated, but in the earlier part, the beginning of this discussion, you actually had 3 groups of hospitals. The third group being the 3 psychiatric and the Mount Washington facility.
And they're at the end.
I understand descriptively, but are we saying then this chart is just for 1 and 2, and you're not reflecting anything in the revenue under the all-payer model, that column, that has anything to do with what you're recommending for psychiatric hospitals in Mount Washington? That 0.7 specifically is what I'm referring to.
This is not about psychiatric hospitals.
Okay.
So this is about hospital revenues under the all-payer model and or Medicare rate setting waiver. So,
okay.
So maybe we can, should we just write a little bit more description at the top of the chart to
please.
make it easier to follow?
Thank you.
So, okay.
So this is 1 the same as 1 on the prior page and 2 the same as 2
yes.
on the prior page.
Yeah, we can reverse the order in the table too, so 1 will be before 2. So, sorry about the confusion level there. Then on
hey,
page,
Donna,
yes,
before we
sir.
switch, I feel I need to make a comment about inflation, and since I have a new audience here, some people haven't heard me say this, but many others have, so let me just bear with me. I think there's, and it's understandable, that when you look at the word inflation, you assume that, okay, hospitals getting their inflation covered. Well, that's not true, and it's very material that it's not true. And I think what is, and I'm not pleading that we get more than inflation. I'm suggesting that everybody around the table understand that there are other costs that hospitals have got to get productivity gains in order to fund them, because they're not being paid by this inflation factor. So what am I talking about? Technology, and I don't mean information technology, although I'll mention that, clinical technology. When here comes the latest implants, and they are better, they are more expensive. You have gender-specific implants, and everybody has to have them. You have pharmaceuticals that in the world of chemotherapy is extraordinarily expensive when new ones get onto the market. Hospitals struggle to say, well, Marylanders won't get that. And of course, IT is just overwhelming. It's the foundation of how we have been operating, and we've only touched that part. And so there's huge investments going there, some of which are being mandated to hospitals. And just to go on for a little bit more, something as simple as implementing ICD-10 coding. Our health system alone, to get that done, is $30 million. And we've had lots of stops and starts. My point is, I don't want anybody to look at this inflation provision and assume automatically, then you've got your costs covered. It is nowhere near accurate. And so there is already, in my view, built-in requirements for hospitals to find productivity gains. And I just wanted to make that comment because I had a new audience here. Others have heard it. So I'll turn this off and we can move on. Yeah, there you go.
And we can come back to this with questions and comments too. And then we move on to the second section with volume adjustment, and I'm paying particular attention to this area because we had transitional policies that I talked about before that effectively limit volume growth under a non-global revenue that is a Maryland resident to, and actually that it should be making sure that we have a distinction. We need, oh, I guess actually we do have that listed there, but to a 1% growth, it's actually 1 to 1 and change after you apply the variable cost factor. And in its earlier comments and in its comments to the work group, CARE first recommended changing that to synchronize that volume governor with the population adjustment so that there wouldn't be a potential something's better because you're low, and so you can get more on the volume governor than you could get under the population adjustment. So if you're in a low growth area, you could get more under the volume governor. So that was a comment that we had earlier in the process.
It was a thing to try to make it hospital specific. So if you're in an area high population growth, you would get more. If you're in an area in low population growth, you would get less. So the volume governor would be targeted to try to keep that in line.
So we've reflected that as a comment here. At this point, the staff hasn't made a recommendation to change that, but it's a comment here, so we'll entertain discussion on the issue here. And I just want to make a quickly flip through here to see if there are any other issues that warrant.
Donna, on page 16, at the top of the page, right-hand column, I think that's 1. Isn't that 1?
Yes.
Yes.
Okay.
Yes. Second sentence says the result was multiplied by a 25% factor. There was no adjustment for avoidable utilization. I probably, if I were writing this, would have written it differently. There was a lot of debate. We used age brackets. We used current utilization trends, which we all debated heavily. The sentence leads one to believe that the 25% factor is satisfactory, and however, there's another opportunity with avoidable utilization. If the 10 hospitals in the room were here that are on CPR, they would debate that the 25% factor was even satisfactory to begin with. So maybe I would like you to consider some altered language there.
Okay. Do you have a suggestion? You can either send it to me or you
I
give
will.
it to me
I
now.
will do that.
I'll be glad to change it.
I would.
Can I suggest one?
Sure.
There was no specific calculation for avoidable utilization because we did a rough estimate, right?
Well, the 25% factor I would suggest was not adequate to begin with. So it was used, though.
Right.
So so perhaps we use the 25% factor in which I'm struggling for words right now. So why don't I just send it to you? Is that okay?
I mean, the adjustment that was made was based on utilization that was apparent at the time. That has changed, and we were trying to get them to lower these hospitals to lower utilization. That was an agreed upon adjustment with all the TPR hospitals. If we think we have something better today, and the TPR hospitals believe that's what they should be allowed, then I think we would be open to discuss that with you all. But what I don't want to do is open it up so that TPR hospitals pick and choose which one they feel is more appropriate for them.
I agree. We had a discussion about the calculation being based upon prior use rates, which we're trying to lower down. I get that.
So
also,
maybe we should just say that it was adjusted for
right.
a rough estimate of avoidable utilization.
Could be.
Something.
But the one thing that we need to all recognize, and this would be for every hospital in Maryland, now that we've added 169,000 or whatever the number is of new enrollees who are going to seek care, that perhaps has not been available to them before, there may be pressure on higher use rates. And it's not going to be the result of anybody not doing the right thing in terms of managing care. It's just it's the woodwork effect of people having, access to care that they did not previously have. Okay.
We're definitely going to take a wait and see and measure attitude toward that, and the evidence so far shows that it's mostly outside of the hospital, in doctors' offices, and drugs, and outside of the hospital for the most part. So we'll have to take a wait and see on that one. So I guess, are there questions or comments about the draft policies that are the potential policies that are written in with these two different types of hospitals?
Maybe a question for clarification. I'm on page 17, and it's the comment relating to AMCs in the middle of the page. I don't know if that's a 1 or a 2 column, but it talks about policies to introduce changing patterns. It's right in the middle of the page 17 on the right-hand side. So the question clearly is one, there are absolutely, people are seeing it nationwide, more cases that are shifting into the AMCs, and clearly we're fortunate to have multiple in the state of Maryland that serve our communities. But we do want to make sure it's the right cases that are going into those AMCs, and not cases that can be done in other centers in a more cost-effective fashion. So is that the balance that you're looking to get out of that comment?
And I think we're actually going to talk about it a little bit further back in the paper, but we're just trying to bring it to attention that there's a policy that's being introduced relative to transfers to AMCs. So the focus of the policy relates to hospitals going on global budgets and then deciding that it would be a good idea to transfer the patient somewhere else to get their care. The AMCs for a particularly sick patient are a great resource. And actually, there might be very positive reasons to transfer patients earlier in global budgets, because you might be doing it to get a better quality result. You might be getting them out of your institution earlier. When we looked at the transfers in, they run up a great big bill, many of them a great big bill before they land at the AMC. So hospitals might say, geez, I'm going to transfer them to the AMC sooner. I think I'm going to get a better quality result. I think it's going to lower my cost. And we just want to have a way to pay for that. And so that's what this is all about right here.
And if I could add to this, I think this is one of the examples where hospitals need to collaborate on an individual basis about the appropriateness of some of these cases and whether or not they can be treated back at the referring hospital by providing some telemedicine type technology, electronic ICUs, so that is, and I think that's how we can collaborate over those that are marginal in transfer.
And so the benefit of approaching it, how we're going to approach it later here in the paper, hopefully, is that we're focused on keeping transfers inside the global budget, not taking it out as slippage, and adjusting the revenue stream underneath for transfers when they increase at a reasonable price that doesn't inhibit their transfer. So that's what we'll get to later on, but that really is the focus there, and we're just trying to bring it to people's attention that that's being done, and that we're focused on, doing it. And if we're going to have the academics on a global budget, that it's going to be, next year that we want to do that. Otherwise, we have to set aside slippage for it, and we're not anxious to put more things in slippage. So that's really why we're addressing it that way.
We call that practicing at the top of your license when we talk to our physicians, telling them to manage the patients to the fullest extent that they can within our facility.
And you know, there's all different approaches. Some facilities with the shortness of length of stay in surgery patients and more medical patients moving outpatient and off the campus, some hospitals really don't want to staff an ICU at the intensity level, and so they're going to transfer those patients more frequently because they don't want to staff an ICU under the new model. They're going to decide that that's not an efficient use of their resources. So I'm just, so I don't want to presume exactly why they would make that decision, but just what happens if they make the decision to increase transfers or reduce transfers and try to tee up that approach. So making it so that it's actually an easier approach than slippage.
Donna, while we're on this page, and actually right above the section we're just talking about, under the market share adjustments, you talk about the fact that we'll address that by the work group after completion of the balanced update. And I know we're going to be talking about Germantown shortly, but as it's described in both the chart that we went through earlier as well as in the discussion about Germantown, it appears as if we're talking about doing a market share adjustment for that facility as part of the balanced update. And so I'm curious as to why we're talking about here that market share adjustments will be addressed by the group after the completion of the update, when in fact it seems we're making an exception for the Germantown facility. And I don't know whether we want to discuss that here or when we get down to the Germantown discussion, but either we're going to have a market share adjustment as part of the update or we're not. But I'm suggesting I think we need to be consistent across, you know, whether it's going to be part of 15 or not part of 15, because we don't have time to address just how we're going to calculate market share adjustments.
Well, the Germantown facility was addressed in the commission policy that we were going to have the Germantown facility coming online and that we were going to make adjustments. So it's a major event. Right. And we have contract provisions that allow for us to make market share adjustments, and quite directly, we have contract clauses in hospitals in the service area to address the Germantown hospital opening.
Right. And all I'm suggesting here, as I read this sentence, it would lead the reader to believe that we're not going to be doing market share adjustments in this initial year, because we haven't. We're deferring that discussion of how to do market share adjustments until after we've completed the balance update. So all I'm suggesting is, in terms of the wording, we probably need to at least illuminate at least the one exception that we have to make in this initial update.
And I guess we should also just eliminate the fact that we address it in contracts. So there is actually the potential to make a market share adjustment in the global contract. So it is actually a contract term. So it's not, that's fine.
Just a semantics issue.
Thank you for, we'll work on the wording to make it clear that we're not saying, because we don't want to say that a market share adjustment won't be made. If somebody takes their program and they put it in a freestanding setting, we are definitely going to make a market share adjustment.
Absolutely.
Right. But there may be more global approaches to market share adjustments that are thinking about.
So this really should be focused on more global approaches.
Or systemic approaches.
Systemic.
Right. And then just on the bottom, the discussion about adjustments as needed to meet the requirements of the all-payer model. I'm just, and again, this is the bottom of page 17. I'm wondering whether that reference needs to be in both columns. It appears as if we're only making those adjustments for the hospitals that are not under global models. Is that correct? Am I reading that? Was that intentional?
that is not intentional. That that dividing section between the two models should be eliminated. Thank you for bringing that to our attention.
And Donna, that should be for all three of them, right?
Right.
All three.
The governor?
Yes, the POW, the quality-based, all of those are, that middle bar was supposed to have been eliminated, and we may have had some table versions there.
Thank you.
You also have a question on the phone related to the AMCs. Charlie Royland asked on the transfer to AMCs, does the AMC language limit this issue of transfers to certain hospitals? Which hospitals does this mean?
The hospitals that we're specifically focused on are Johns Hopkins Hospital and University of Maryland Hospital, the two academic facilities. So we were specifically focused on those two hospitals only. So we should make that clarification that we're talking about just those two hospitals. Are there other comments on the policies that are laid out in the tables? Those are some clarifications. Are there comments at this point on the inflation difference or the initial care first comment on the volume adjustment? Is there any do you have any additional comments that you wanted to make on that at this point, John? So now we're moving on to the section of revenues under rate setting, but not in the all-payer model. And this is number 3, model number 3. We'll get that noted here. So that's the psychiatric hospitals and Mount Washington Pediatric Hospital. Basically outlining that last year the HSCRC staff used a slightly different update process for those hospitals, looking at the Medicare update approach and effectively utilizing that approach for those hospitals. And I've been told that some of those hospitals might be coming to see us, but I know Kristen has a couple of those hospitals. Do you have any comments on that, Kristen?
I guess just, I don't know if we developed a formal policy last year or just an approach. So my concern would be last year we did take an inflation minus productivity similar to what we had applied for the acutes because everybody took an ACA offset. And we were working within a pretty constrained environment last year, and I would just, I'm not sure that a productivity minus inflation approach on the non-governmental payers is the right approach to take when there are other productivity gains that we have to get. Because, for example, we don't get full funding on UCC for the non-waiver hospitals because Medicare and Medicaid don't pay the rates that are set by the HSCRC.
Right, and I would add to that, Kristen, just to follow up on what Hank said with regard to the costs that all of these hospitals are incurring. if we truly want these psychiatric hospitals, Mount Washington, to be part of this collaborative effort, we need to be successful under the waiver. We need to make sure, just as we've argued for the general acute care hospitals, the need for these facilities to have the sufficient resources, paying something less than market basket, which, as Hank had indicated earlier, is not really their true underlying costs, I think falls short of what they'll need to allow them to collaborate with the general acute care providers on improving population health.
Are there other comments? So the next section gets into the uncompensated care, and we had a work group meeting, and there will be some additional activities. We actually flew through a lot of materials in the work group, in the sub-work group on UCC, and looked at both looked at a series of issues, and we've reflected them here. There will ultimately be a separate policy paper. So this is really not intended to get us through all of the weeds on, and we're on page 19. This is not intended to get us through all the weeds on what the policy changes would be. It will be covered in a separate document. But in order for the Commission to make a balanced update, ultimately they have to know how much the increase has to be funded for UCC, and they need to know how much of a decrease there will be for uncompensated care from the implementation of the affordability from the ACA. And how the money gets distributed among hospitals isn't something that the Commission has to consider in the balanced update. That has to be considered in an equitable manner, but it's not effectively part of the balanced update consideration. So we're not intending to get into all of the different regression adjustments that, that we're looking at here. But what we are focused on here is that there was a 0.38% increase in bad debt and charity care between fiscal 12 and fiscal 13 that would be funded under our current policy. And so that will be put into the rate formulation for fiscal 15, and the Commission needs to take that into account. All of the regression variables, et cetera, we're not going to discuss them today. They're being vetted and looked at. The impact of them is being looked at, and will be coming back to the subgroup and then ultimately back to this group to discuss them some more. There was, and actually there was a charity care multiplier, and again, this will be handled in the separate paper. I might even take it out of here because it really it isn't really about the balanced update, but there was a charity care multiplier that was used in the past, and the subgroup discussed it and agreed that it should be continued to be suspended, that it wasn't at this point, especially with the reductions that are happening from the ACA, that we didn't need that in place at this time. The second area that we looked at is the amount of uncompensated care reduction that might occur from enrollment in PAC. We had sent you a paper going into that into a great depth, and that would result in about a 15%, an estimated 15% reduction in uncompensated care. Data is being shipped out to the hospitals so they can kick the tires on that. That's a very large, some hospitals would see a more than a third reduction according to the estimate. So it's very substantial, and we want to give folks a chance to kick the tires, and we'll be able to do that and be able to get back to the commission by the May meeting. But that's the plan of attack, is to make sure that we know how that there's no issues with that data before we take forward a specific recommendation. But right now it looks like it could reduce the uncompensated care by about a percentage point. Any questions or comments about that?
The only comment, you talk about packages. I brought it back to my story here. My experience in working with emergency physicians is that you probably talked about this in your committee, that most of the PAC recipients had no idea that they didn't have coverage for emergency care. And then when the state did implement the payment for the hospital side, I don't know, maybe 2 years ago, 3 years ago, Steve, you might remember, they didn't on the physician side. So this was a case that was unique, where the PAC recipients thought that they had insurance, and so I think that the level of uncompensated care for this population, my gut from is significantly higher than from the uninsured population.
Yes, I think that's what the study showed. It is significantly higher, and so that's built into the estimate of the relief of uncompensated care, if you will. So the next area that we discuss here is the Germantown Hospital and the proposed staff approach to adjusting for the Germantown Hospital. Effectively underlying our new model is a 50% variable cost factor. So for those hospitals that are on a global budget, the staff is proposing to make a volume adjustment for volumes that move to the Germantown Hospital at a 50% variable cost adjustment. The Germantown Hospital, on the other hand, is picking up the inbound revenue at 100% variable because it's a startup facility. So that's what creates the gap of unfunded, if you will, slippage, is the gap between 50 cents on one hand and 100 cents on the other hand. And we're primarily focused on making the volume adjustment for 3 hospitals in the Germantown emergency room, because those are the facilities that are serving that area. We're focused on trying to make that relative to the base year of fiscal year 13, looking at the equivalent case mix adjusted discharges that existed in that time frame, and then moving forward through an implementation period. Then also looking at the ultimately how that population will be affected in the population adjustment, because as the new facility comes on and has market share of those population, then it will receive effectively the population adjustment for those individuals. So that's really an accounting of how that happens. For Holy Cross, we expect to make a prospective adjustment because they said in their CON application how many patients and of what sort they were going to move. So we would expect to make an adjustment for their market share shift up front as they open the facility for the hospitals that might be have patients shifting. After that, we would expect to make that slightly in arrears after we know what happens, and in order to maintain a conservative factor for several reasons. One, that we're making an adjustment in arrears, and secondly, there may just be some volume growth. When you have a new hospital that isn't really a volume shift from another hospital, we are proposing to use a 70% slippage factor against the revenue in the first year. Obviously, in years beyond that, the impact will not be as significant, and you know, we will hope to have that the slippage factor beyond the first year drops considerably because you've already funded it in the first year. So that's the calculation that we've gone through. It's about $80 million in revenue. So 70% of 80 is $56 million, and that gets converted back to slippage.
That's the 0.41 that you had in that earlier
Yes, but
worksheet.
please check my math.
Yeah.
And I wasn't trying for complete precision at this point, so it's.
So Donna, the 0.41 we're talking about is not a one-time number. It doesn't reverse back the following year. It stays permanent, right? So it doesn't become a new source of revenue in the second year of this arrangement. So right, it's permanent. The use of that 0.41
it's permanent.
Across.
It's permanent, unless you know, unless we have a heavier market share recovery. But then the difference would be the maximum amount would be 0.5 because we're not going to get more than 0.5.
So is this indirectly creating a capital policy?
No. This is
a one-time.
This is a one-time issue that existed. The commission specifically addressed this one-time issue as a transitional policy and not as a permanent capital policy. This is not a permanent capital policy.
We will try real hard to remember that.
Maybe we should actually write that here to make sure that it's not taken as a not permanent capital policy.
Well, so much for that fairness comment we started with earlier then. So just a couple things. First of all, I appreciate the wording in there that it's not the intention to try to hurt the other hospitals in the region, but I do want to push back a little bit on the no population adjustment aspect to this. I understand the market share. So our ability after the fact to look at real market share shifts is a legitimate issue to discuss. But the action of, well, we're just going to hold all the population growth and give it to one hospital, in my mind, that tips the scales towards, you know, hold on. Now you are hurting other hospitals, and you don't even know the results yet. I look at our area in particular. We're far enough away from Germantown. I know the growth going on in our area. We don't have population growth in our area, and it's just being sucked out of our place and just unilaterally given to, in this case, the New Germantown Hospital. I appreciate the fact that the commission made a transitional decision, but
well, they didn't make that decision yet, so that's actually open for discussion. What do other folks think about that? It's there because that's what the CON process said. But if folks say, if hospitals in general say, you know, that really doesn't make sense today, that piece of it, because that piece of it, the piece that's about how much Holy Cross is going to transfer, then we would expect them to transfer that volume. But we don't necessarily have to lock in the population piece, but we'd like to hear from other commenters.
So I'll give one comment. Obviously, this one does not affect our health system directly, but I think it does indirectly, and I think it's unnecessary to do it, but I think it signals to hospitals that there may be something that's just not logical. I would just say put this in the same bucket that if, in fact, the patients decide to move away from these 3 hospitals, then make that decision. But to do it ahead of time, it seems like it's not much, the juice isn't worth the squeeze, so to speak, on this one. It's my reaction, but people will overthink it and become a little concerned that, well, what's the logic in that?
Are there any other comments?
Yeah, well, I will second that. I think it's the other issue I would add in terms of actually writing the report. One could argue that, in fact, more than just these 3 hospitals might be impacted by potential movement of those patients, and we won't know that again until something in arrears. So I would also just be concerned about listing specifically, other than Holy Cross Hospital, that under the CON had indicated those patients would move, in listing any other hospital, Shady Grove, Montgomery General, MedStar Montgomery General, in this paper for now. I think it's important that we at least list that there could be other facilities impacted in that way.
As a matter of fact, I think they actually talked about other facilities and movement from other facilities, but that's all hypothetical.
Right.
Does anybody have a contrary opinion to say we should charge that population adjustment back against those hospitals, or should we go ahead and take it out?
I'm not sure this is contrary, but I think that there should be a look back and a look at the market share that's taken by the new hospital and the market share that's lost, and then perhaps there should be a reference to the market share policy that you're developing so that you can see what the true shifts in the population are. And you're not going to know that out of the box. You're going to know that 2 or 3 years down the road. That may be the way to address it.
Well, actually, should have it 1 year in, and we can adjust the population in the year after it happens. So instead of doing it up front and taking all of the population adjustment instead of just the market share piece, we can do that. So I'm hearing that there's a
just one comment on that, because there's a lot to opening a new hospital. You get a pop originally with the opening of the new hospital. Over years, though, you see that go back. So you get the original pop, it's all good. A couple years later, maybe it's a convenience factor. Maybe other hospitals in the region are offering services that are comparable or maybe even better than that, and patients will come back to a more convenient facility. So I acknowledge new hospitals get a pop. I don't know if that's actually a good thing long-term for the industry. It should be more about quality than it is how your facility looks. But I will tell you, after time, those patients do come back to their local hospitals. Now, the market shift adjustments may take care of that. But it is interesting. They got theirs at 100%. Yeah.
Well, what else can you do with a new facility? I mean, let's face it. So, what I've heard is, look, we don't need to name the other hospitals. They know who they are, and it's not important to name them except for Holy Cross and the prospective adjustment. And we should eliminate the the prospective population adjustment.
I think, just as important as it is to not name the hospitals, we don't want to presume. I think there could be market share shifts from other area hospitals, and we want to make sure that we're not going into the market share adjustment with the presumption that it's larger for the named hospitals than it really is. I think we need to prove that out.
Right, which is why we thought that it should be reserved at the 70% level, because we're not so sure especially in a hospital that has a lot of outpatient volumes, we're not always sure that they're going to come from another hospital. They might come from a doctor's office. So we want to make sure that we take enough of a reserve against the number in the statewide cap.
Yeah, I think that to some degree we're struggling with an inherent problem with prospective budgeting in the case of a new hospital, right? I mean, it's impossible to forecast what a new hospital's revenue is going to be and what the fallout will be for its competitors. And the problem is we're dealing with a statewide ceiling, and therefore there's going to be a new hospital. It's going to have some money. It needs to have some money that needs to be estimated up front, and some of that needs to be taken from its competitors. And by definition, the choice that's made about those dollars is going to seem arbitrary, and so we just have to accept that. So I actually think the basic approach in here of saying we're going to allot some dollars to this new hospital, and we're going to take some from the surrounding hospitals, and it's not going to be a dollar for dollar shift. It's going to be 70%. I think is pretty darn reasonable, that basic framework. That said, I'm not sure it makes sense to say that 100% of all the population growth is going to go to this new hospital. I mean, because that doesn't seem to make sense to me, right? I mean, you know, more people are going to live in the region. Some are going to go to this hospital. Some are going to go to that hospital. But I think the basic notion of saying the demand for hospital services in this area is going to change, and a significant portion of the care that was furnished by competing hospitals will now go to the new hospitals. We're going to estimate that as best we can, and after the end of the year, we're going to look and make adjustments based on what the actual patterns of care were, and then we're going to rebase that going forward. I think makes a huge amount of sense. So I think I agree with your summary. I think that it does make sense to take out the notion that every single jot and tittle of the population increase is going to go to the new hospital, but I think we just have to suck it up and say, yeah, it's going to be a prospective budget for the new hospital, and that means the other ones are going to suffer some dollar reductions, and there's imprecision in that. Okay. That's the new world we're in, folks.
Well, the new world we're in is the fact that we haven't actually seen that shift take place.
Right.
So you're going to be using an analysis made of the hospital who was motivated to sell this project to say, well, that is the quote Bible we're going to use going forward. That's not the case. I'm okay with us looking after the fact and making appropriate adjustments for real market share. I'm not opposed to that concept. But there are many of us who built hospitals that were based on assumptions that haven't played out the way we thought they were.
Sure.
That's called risk associated with managing your facilities.
Sure.
That's back to what some of the comments about capitalism. There's always risk associated with making these things. They should have some risk associated with undertaking a very expensive type of issue. I want them to have some risk associated with it, just like I accepted risk when we built additional facilities. We don't want to take that away. All we're saying is let them have a little risk, let them feel a little bit. If it works out the way they proposed, there are legitimate market share rules that are into effect that will give them reimbursement. That's the only point.
Well, I mean, what I hear you saying is that the documents they prepared as part of their CON application should not be treated as holy writ, and rather that HSCRC should exercise independent judgment about what, in fact, a likely reimbursement level can be forecast for that new hospital, and I think that makes sense.
So if I could add to this, make sure I got this right. So the immediate sources of funding Germantown are money moving from Holy Cross, the parent, into that location. That'll be a prospective money to help. Secondly, every Maryland hospital is going to be using part of the 3.58% that we otherwise could maybe use for other things, and using that. That's going to be their startup money.
Right.
And then after, in fact, patients start shifting to that new place, would there be a market share movement, right? Has I got that right?
Yes,
So
and we're going to take the population out of the equation, the upfront population, which is, I think, was about $5 million. But and it's really, as you all say, it's really not worth the heartburn.
Thank you.
Anyway. The part of this that I have a real hard time getting my arms around is I come at this from the other end of the tunnel. I think in terms of a patient going to a hospital, the hospital billing an insurance carrier, the insurance carrier billing me. I get the sense here there's this thought process that you have a single pot of money and you can just kind of deal it out like a poker player. And I'm not quite sure how this plays out on the ground. You know, when Germantown Hospital opens its doors and starts treating patients, how does the money start flowing in? I mean, you
it's
guys.
It's going to bill you, and you're going to pay it, and it's going to. And the estimated amount of money for fiscal year 15 that the hospital has submitted to us is $80 million. So they'll get rates.
So they'll get a per case rate, basically.
Yes, they'll get a per case or a per unit rate, and they'll bill it and get paid. And the estimated amount of that is $80 million in fiscal 15, and so it'll be just like any other.
So there's an inherent assumption in here that, I mean, contrary to the old adage that a built bed is a filled bed, that overall per capita utilization in the state of Maryland will not increase beyond what it does now.
We're not making an assumption.
It's just being shifted.
We're not making that assumption 100%. We're hedging on it a little bit.
Okay. And so getting to the point of risk, which I think is a valid one, what's Germantown Hospital got at risk on this?
They have at risk of whether they can actually get $80 million worth of revenue. It's a new environment. Volumes are harder to gain, and some of their payers are very good at managing care. One of their payers is Kaiser Permanente. They're very good at managing care, for example. So what if they don't? So their risk is they may not get $80 million of revenue.
Okay. I'm anxious to see how it plays out.
Also remember that I mean, the whole idea of approving a new hospital presumes that there was a need for those services. So the question is, if state of Maryland is operating under a total spending limit, the question is, where does the money come from out of that limit to support the existence of an extra hospital? And you know, I concur with the decision that's been reached here. I think basically it's the system that has to support that, not just the hospitals nearby. And I think where we've ended up is essentially that. So we're saying basically, okay, we've got a total amount that's going to be spent in the state, and that's going to meet the needs of Maryland residents better, and it comes out of the whole system. And then as it plays out and we see where patients go, then the money will follow those patients.
Right. So they're not getting a global budget of $80 million. They're going to get pay-as-you-go until they reach the time when they said they were going to be full in their CON, or when they reach the revenue cap in the CON, whichever comes early. When they hit the revenue cap, then they will go to a 50% variable, or they'll go on a global budget. So whatever time frame comes earlier, the time in the CON or the revenue level. I'm going to skip past the demographic and go to the academic medical section center, and we can come back to the demographic if people have comments on it. But I just wanted to make sure that we had time to look at this. And this tees up the conversation that we started in the chart earlier about a couple of categories of patients for academic medical centers that we believe require special attention. And the first category relates to the categorical exclusions, and that is the transplant, some small sliver of oncology patients. There are some burn patients and some thinking of one more patient category. I'll think of it in a minute. So, pardon me? No, it's a very small sliver of patients. what we're focused on doing is to create a budget for those patients under a global budget, and to fix that budget into place for a year, and to update that budget annually based on actual experience and volume. So if the volumes go down, the budget will be reduced down. If the volumes go up, the revenue budget will be increased using the factors that we're using for the system. But that is the approach that we want to take, rather than excluding them from the global budgets and addressing them as slippage, to create a prospective budget with an annual update. And that concept, we gained that concept through interviewing Kaiser Permanente. They have a lot of hospitals in California, and we talked to them because their situation seemed the most relative to what we're trying to do here, and that was one of the ways that they deal with these patients. So we will deal. So that's a different method of addressing volumes for those patients than population adjustment, and so we will have to determine a budget for those patients, and if there is growth projected, we'll have to set aside the growth. So, for example, there is a little bit of growth going on right now with kidney transplants and liver transplants because of living donors, and we'll need to make sure that we're funding that appropriately in the categorical exclusions. The next area we started to talk about before, which is the transfers in. And in the case of the transfers in, what we're focused on doing is developing a base period of transfer in cases at Johns Hopkins and University of Maryland, and then tracking changes that occur over the base period. So if the cases increase from an inbound hospital, then there would be a transfer to the academic global budget, and a reduction, I'll call it the community budget, for an increase in transfers in. If it went in the other direction, then there could be money flowing back in the other direction. So we're looking to create an opportunity to let money flow with changes in transfers in. We're focused on doing that at a fixed price because we don't want to create a barrier to transfers. We don't want to shift risk back onto the community hospital for an outlier type of case. And so this is also the model that we talked about with Kaiser Permanente about how they handled some of these types of cases in their California facilities, that they moved money from, they have global budgets for their hospitals, and they move money from one hospital to the other for these types of cases.
I was going to say, is that fixed price not the same both ways? Meaning, if you have a volume decrease or a transfer decrease to the academics versus an increase, is the fixed price that will be moved between the organizations the same amount? No, I'm saying if the fixed price of an increase in transfers to the academics is $5,000, is that same fixed price what will move into the community hospital if transfers go down? Is it truly a fixed price?
We will the transfer back. We should continue to look at that through the data development to see whether that's the right answer. I'm not against the answer of the same amount going back, but it's something that we would want to continue to look at. It may be that it makes sense to have it be a different number of what's going back. So, but the transfer in the academic facility has GME and other types of things built into their rate structure. So it may make sense for that number to be a little bit higher than what would be going back in the other direction. I haven't really figured out the going back in the other direction piece of whether it should be exactly the same number. But the piece going in, that piece is making some sense.
Yeah, remember, if it's a reduction in transfers, the GME is probably going to sit in the hospital that's still good as well, like a Sinai that you're not considering to be an academic medical center. So
right. So right now, for ease of administration, at least in year one, we were thinking about making it a fixed number in either direction. But we don't want to get too complicated in year one, and we can refine it as we move down the road. So keeping it straightforward and simple, not putting risk on the transferring in hospital, and recognizing that this is an area that we'll need to continue to monitor and make policy changes and probably rebase. So if we end up at the end of the year and the academic is in the hole from a cost standpoint because of the types of the case mix of those cases, we'll end up needing to rebase that.
So Donna, your point, I appreciate you saying it, that this is going to have to evolve, and it's also about data and what we collect and don't collect. So off the top of my head, I want to say that 40%, which is about 5,000 cases a year, come into the university hospital directly from the emergency rooms of Maryland's hospitals, not from an inpatient. And I think much of what we're talking about here is a policy about inpatient to inpatient, i.e., that, for example, there's somebody in an ICU that is not in a condition where they want to keep the hospital there, patient there, and the physician wants to transfer. That's much of what we're talking about here. I don't think we have the data, which is an increasing number for us that are coming directly from the ERs. And I think we're going to have to put that in this mix too. All the data that we, and I think it's...
There are some, oh, I'm sorry.
No, I just think that they are examples where hospitals say, I don't want to admit, only to turn around and transfer later. And I think that's the right thing to do, but it's really not in our data. It's in our data, but it's not in other sources. So I think we need to collect that data and build out this conversation.
There are a few patient types that we would intend to exclude from that list of transfers in, and those would be things where there's general competition, like angioplasty. So we're not interested in having angioplasties on the list. So we're in the process of putting CRIS data into play to make sure that we do the best job we can to accurately measure the base period, and then we'll be back on this topic some more. But we wanted to tee it up now because the issue is if we don't put it here, then we have to put a provision in for slippage. So we want to bring it to the table and say we'd like to do it this way because this way we can do it inside of the global budget world, and we don't have to put in a slippage factor for it.
So for the budget for categorical exclusions, are you envisioning one sort of statewide budget against which each hospital would bill, or are you envisioning separate allotments for each hospital for the categorical exclusions?
Separate allotments, annually rebased.
For each hospital?
For each hospital.
Okay. Notwithstanding the rate fluctuations that can happen.
Annually rebased. Okay. We place a high premium on predictability. So we would rather overpay a little bit and then take it into account in the next year than to have a surprise. So we're trying to avoid surprises. So we're having a maybe we'll get a at a future time we won't be in that same situation, but right now we really don't want any more surprises than necessary.
Right. I mean, an alternative approach would be to say, let's set aside a statewide amount to cover these contingencies, and to whatever extent an individual academic medical center encounters one of these cases, it can bill against that statewide fund. And at the end of the year, if we wind up, exceeding that amount, we'd have a pro rata reduction. At the end of the year, if we wind up underbilling, then we can save the excess for the following year. And that, has some advantages in view of, I think that may be an alternative worth thinking about.
It does, and it does have some longer-term advantages. There are some issues with it, and the issue that Kaiser, brought into play is they said that, the hospitals would be individually focused on their productivity policies, et cetera, and so we weren't at this point prepared to overlay productivity policies that would be required if we put it into a statewide pool. So we weren't prepared this year to address care management and productivity policies required to put it in a statewide pool. So that's why we're not thinking about that this year. It might be a good thought next year as we see how it plays out. But that's at least the thinking process this year for not putting it statewide.
Donna, is it all the same traditional categorical exclusions that we've had in the past?
Yes.
We haven't changed the list of what we consider categorical?
No.
Okay.
On this point of these categoricals, all I'd say is that the biggest risk, and it's the only thing that would concern an academic would be around transplants, and it's about the availability of organs. The wait list for transplants is high in every category just about. And, of course, we have, the good news is a lot of these patients are not Maryland residents, so it doesn't affect the waiver. But you can get some movement in the availability of organs, and all of a sudden here come an extra 40 cases. So that outside that, we just have to understand what that means, and so there's not some mixed message that we don't want our academics doing this kind of work. We do.
So again, this is the first year, and we wanted to try it this way, and there might be another way that comes to light, and this is what we're proposing of how to implement it, and it's based on how Kaiser does it in some of their facilities.
I have a comment on the transfer, and it's not necessarily related to the update, but just recognizing the changing incentives. The previous incentives being keep them as long as possible at the community hospital to get paid more, and now it's push them out as soon as possible, and vice versa. And that I'm worried about a hot potato, like no, you keep them, no, you have to have them, and it's always on the margin, right, where it's a gray case, medically. Not that everyone doesn't have the patient's best interest, but financial incentives influence behavior. So I would just say that whatever you can do for an early warning system, as much real-time monitoring of this is the canary in the coal mine on people responding directly to incentives in ways that we perhaps might not want. And to make that information as public as possible.
I think we really do want to monitor it as quickly as possible, because if somebody might be generating a payable and somebody else is billing for the case, we want to get the money moving.
I'm talking about it more from
I understand you're interested in the policy, and we are too.
Right.
And the data is available through CRISP. There's actually almost instantaneous available data of transfers. And
I want that more public. I guess if you're looking at it and you're seeing blips, put it on some website where the consumer advocates can go look at it or something. I want it not just to be a conversation among HSCRC and the hospital.
And you're going to put language in that paragraph in the paper that explicitly says that this is a proposal for a first-year policy and that it's going to be monitored and potentially revised, so that the commission's clear.
Because one point about Mary Jo implies is that the incentive structure would change if there were a statewide pool against which the recipient hospital could bill. Right? In other words, if a sending hospital says, well, we want to get rid of this hot potato, and the recipient hospital is going to get the same amount of money no matter how many hot potatoes come in the door, the incentive is the same on the recipient hospital side. Nobody wants the hot potato. But if the recipient hospital knows the more the more categorical exclusion cases come in the door, if the recipient hospital knows it's going to get paid for however many categorical exclusion cases come in the door, then it doesn't have that incentive to push the hot potato away. So that would ameliorate the incentive that you're talking about.
Right, and that's why we're saying that we want to do this, is so that that there won't be an incentive against taking the patient.
No, but in other words, my concern is if you have a global budget that's hospital-specific for the academic medical center, then why should the academic medical center take lots of categorical exclusion cases coming in? It's not in its financial interest.
So if I could,
right. Well, but in other words, if the transfers coming in is going to be a case where it's a transplant case or another categorical exclusion, in other words, if you don't have an exception for a facility-specific global budget that allows a very high-cost patient to be billed for separately, then you have some problematic incentives that you set up. That's my concern.
if I can just make a comment, this may put some people at ease or make people worry. Believe it or not, hospital executives cannot always control physicians. And let me tell you, when it comes to transplant surgeons, they care about the patient. They are not going to deny access because I say so. Trust me. And so if I can put you at ease, another way can worry you.
Another bit of comfort is that in Medicare, patients like that generally are money losers, and I'm not aware of any studies that have found that there's a problem with those patients not being able to be transferred to where they can be treated. So,
I think there's a lot of data that the commission can use to track all this information. I mean, the issue of transparency, I'm not opposed to more transparency in the data. But I think we do also have to recognize Maryland is a high utilization state, and there are actually cases that shouldn't be going into hospitals, no less transferred. So part of what we're trying to accomplish here is to make sure patients that belong in the right hospital get to the right hospital. Right. And that's going to be a lot of data management, and it's going to take us, I think, a few years to get accustomed to finding that right place for the right patient at the right time. That is our overall mission, and data is not perfect, but we'll use what we have, and we're all going to be, I think we're all going to be equally uncomfortable for the first year or two, but isn't that the sign of a good deal when everybody is equally uncomfortable?
Sure. Well, 3 cheers for discomfort, but there are other examples beside Kaiser of places that have dealt with global budgets, and in general, they have established alternative supplemental funding mechanisms for those small number of high-cost cases that can consume large amounts of hospital resources that are not terribly predictable. And I think it behooves us to seriously consider doing likewise.
I think as we move along and get more details, I think that we can continue to evolve the model and policies. And we don't. The thing that we're not doing is assigning the whole cost of the patient to. We're not assigning patient costs to. For the entire cost of care. So we're not attributing patients to a particular system and saying you have to pay for the whole cost for that patient no matter where they go. It is each hospital taking control of its own budget, which is a little bit easier to deal with. than the alternative system of where risk is put on a hospital for a patient that goes to a different hospital. So I think that is a difference in what we're trying to do here than some of the other global models that I'm quite familiar with, where there's actually a great deal of risk from what might happen in somebody else's facility. And we're avoiding that at this point in time. We'll talk about it again, but it's not on the table right now as part of the model that we have in play now. Well, that was, we made it through a lot of content here, and are there, and we're going to take the comments that were made and reflect them in the document. There will, obviously, we won't actually address the update itself until the next meeting, and we have some homework to do to be able to give the information that's needed for that. Are there comments from the audience about, I'm sorry.
Is there a time when, because I know I, for one, would like to go back and read through this report again and kind of be able to assemble my thoughts, given the discussion that's happened this afternoon, and get any comments back to you? So is it like, if I close business tomorrow, or, can I send you those?
Well, we can take additional comments by close of business tomorrow. This is a draft, and we can take we'll take changes in this all the way up to the right before the next commission meeting also, and also we've asked a couple of members of this work group to serve as discussants, if you will, with the commissioners to go over this. It's a very large document with a lot of policy implications. So we drafted a couple of volunteers to be discussants at the next commission meeting. We'll draft other volunteers for commission meetings when we get on to our May topics. But for this, so we wanted to give the commission an opportunity to have some of the work group members at the table when we present this information, and we thank those of you who we have volunteered for that effort. So we appreciate that. Are there any other questions or comments from this group before we turn to ask the audience if there are questions or comments? Audience? Yes, sir.
David Mann from Maryland's Office of Minority Health and Health Disparities. And just a short one on page 2 where there's the bullets on goals. I propose maybe adding one that would say promote health equity. It's kind of in the concept of the triple aim, but I've often found that if it's not really explicitly stated, it's one of the things that's easy to overlook.
Are there any other comments? Well, thank you for being very productive, and we're 15 minutes behind schedule. I apologize for that, but we did cover quite a bit of territory today, and thank you, and we'll look forward to our next meeting. Thank you. Thank you.